Good morning, everyone. Welcome to the Profiles Breakfast Series, which is sponsored by the Gazette, Growth Partnership for Ashtabula County, Leadership Ashtabula County, and Kent State Ashtabula. Before I introduce the speaker this morning, I'd like to make a plug for the CDC campaign. You have information on the tables this morning with a free pen promoting the CDC campaign. Dr. Herpin is here this morning representing the CDC trustees. There are several very worthwhile projects in the CDC campaign this time around, one of which is the parking lot project at Kent State Ashtabula, which is near and dear to my heart. There are several other very worthy projects that are listed in the brochure: the Walnut Beach revitalization, the Metro Park, Cedar Quist, Orwell Multi-Sports Complex, the Art Center, the Conneaut Art Center, and several others. We're really still in the thick of it in terms of the CDC campaign. As you head into the end of the year and consider where you might make gifts before the end of the year, please consider the CDC campaign. If you have any questions, the number for CDC is on the brochure. Please feel free to contact Melinda McNutt, who is also here this morning. There she is. About the campaign itself. So thank you for your consideration of the campaign. It's now my pleasure to introduce our speaker this morning, Christina Canfield. I was pleased to see that Christina received both her bachelor's degree and her master's degree from Kent State University in nursing. She has worked in several capacities at the Cleveland Clinic for a number of years. She's currently a clinical nurse specialist where she oversees and coordinates the clinical components of a homegrown intensive care telemedicine program. She has worked in a variety of capacities at the Cleveland Clinic over the years. She's also conducted a number of research projects on topics from telemedicine to spirituality. She's authored a number of publications and also done multiple presentations both across the state and the nation. So we're very pleased this morning to welcome Christina Canfield.
Thank you. Good morning. Thank you for coming. Happy to be here. I'm going to be talking about the electronic health record, from home to hospital. So the electronic health record is what we kind of used to refer to as the electronic medical record, or the EMR. Really going away from that term, going toward EHR, because it's more than just your medical records. It's actually a record of your health and your management. Okay? So what the electronic health record does is it links your care, your health, and many of other components of about you from hospital to home to medical office. So there are kind of three stages I'll talk about: where we were, where we are, and then actually where we're going. And in the introduction, she told you that I am the program manager for a telemedicine program. I will talk about that at the end. I'll explain that whole thing for you. That's the where we're going part. So where we were, there was lots of paper. If you think about going to the doctor, they had your chart. They would open it up. They would write some things in it. Your doctor may or may not have written a handwritten note. They may have dictated a note that was then placed in your chart. If your physician had two offices, they may have had your chart there, or they may have forgotten to bring it from the other office. So there wasn't a lot of continuity. And so with the advent of the electronic medical record, or the electronic health system, physicians' use actually has increased substantially since 2001. Now, there are some government incentives for using electronic health records. I am not going to go into that a whole lot. It's called meaningful use, and there are incentives for doing so. And the whole reason why there's a push for doing so is to ensure continuity of care, and I'll talk about continuity of care. So in the past, this is where we were. We were siloed. Your records lived in several different places. Everywhere you received care, they would start a different record. So you went to a physician's office here, they started a new record for you. You went to one there, new record. You got sick on vacation, completely different record. Pharmacy, completely different. Hospital, completely different. And they didn't talk a whole lot. When they don't talk, things happen. You can have mistakes in medications. History can get a little bit convoluted. And so what the electronic health record does is it funnels it all together into one place. One repository where all the information somebody needs to provide your care can be found. So it eliminates the silos. So that was the past. Where we are now, moving toward the universal use of electronic health records. It is a requirement associated with some reimbursement again, and it's a term I'll refer to as meaningful use. I'll give you some websites at the end where you can learn more about meaningful use if you're interested. But what we're moving toward again is these universal records. There's not just one electronic health record system. There are several. An Epic system and a Cerner system are probably the two biggest in the country, but there are certainly many others. And so what can you actually do with access? You can do a lot. I'll talk about that. Okay. So we're closer to about 80% of hospitals and physicians' offices using some component of an electronic health record. So what does it do? Again, it's all about continuity. It's all about assuring safe care, knowing your history, your medications, and your whole record. So it's continuity. This is, with the power of the electronic health record, I can see a nurse practitioner at a Minute Clinic in Myrtle Beach. And when I come back up here, my nurse practitioner actually sees my visit in my record because it's linked. There's a lot of linkages. And so it provides continuity of care. Continuity of care assures safety of care. So how it can affect you at home, or what can you do with it at home and link to the office? We'll go to those two places first, and then we'll talk about the hospital. So one of the most powerful ways that we're using electronic health record technology now is through patient portals. There are a lot of different patient portals that exist. There's NextMD, Clinic Connect, there's IntelliChart. MyChart is the one used by Cleveland Clinic. I'm not endorsing it, it's the one though that I'm most familiar with. But patient portals are secure websites that give patients 24/7 access to their own personal health information. So it's not a secret. No aspect of your personal health information should be a secret, okay? So you can do it anywhere with an internet connection. I have an app on my phone where I can log in with my secure password and I can see my cholesterol results, the last 10 cholesterol results I've had, okay? It charts it, gives me a nice way to look at it. I can communicate with my physician that way as well. So you have a secure username and password, and you can do a lot of different things. Again, I said I can look at my labs. I can schedule an appointment with my physician. I can email my physician, and my physician will get back to me pretty quickly. It eliminates some of the phone call, waiting on hold on the phone. I can also look at the health records of my children. How many people in here have access or use a patient portal of some type? So probably about 2/3. That's awesome. So I'll talk a little bit more about patient portals. Your information that goes into your patient portal is generated during your physician visits or physician or NP, PA visits. It's also generated during a hospital stay. Your radiology reports usually feed into it. Some portals have access also to an education component, and then some do health prevention. So the benefits, okay, so you access your records. Your records are no longer sitting in a folder somewhere where you can't see them. Those are your records. You can be an active participant in your care. Again, self-scheduling. You can communicate with your physician instead of playing phone tag. And key components are click of away. So if you're away from home, if you are traveling around the world and something happens, if you can get into your patient portal, you can provide those healthcare providers with critical information about your history. So it really makes your health record very portable and accessible to you. So there are some myths. Okay, one of the myths, this is one of the biggest ones, is providers don't have time to answer emails. And that comes from both sides. It comes from patients who are afraid to bother their physicians, nurse practitioners, physician's assistants by emailing and asking questions. It also comes from physicians, nurse practitioners, physician assistants, who think, all I'm gonna do all day is answer emails. But what they've actually found is it's streamlined those processes. It doesn't rely on office staff to take a message, relay that message, that provider to either send the message back to office staff or make the phone call themselves. It's a quick email. It takes less time. And they've done studies that find it actually takes less time and makes it more efficient. Another scary one, and for those of you who haven't signed up, you may be thinking, Christina, you're crazy. I don't want all of my information sitting kind of, just as far away as my password on my phone. Any facility that uses a portal is continuously working and improving security features. And that's a commitment that a facility who is going to use something like this makes when they sign up. And it's continuous work. Okay, there's a lot of dedication of people dedicated to the maintenance of these things. And then their biggest recommendation, and this is universal, is using a strong password, remembering to log out. If you log out, nobody can get in. Another myth, age is a factor in portal use. The truth is, if you can send an email, you could actually use a patient portal. Now, portal use is most prevalent among patients between 30 and 49, okay? But certainly 10% of patients 80 plus, okay? And then the 0 to 9, the patients who are under 18, that their parents who have access to the patient portals as well of their children. So the electronic health record from office to hospital, okay, or the electronic medical record, contains and shares information from all the providers involved in a patient's care. And so when you're admitted to the hospital, components of your whole record are visible to those who are caring for you in the hospital. Again, it's the continuity that's important. So this is what people can usually see in a hospital. This is what's generally contained in an electronic health record. At the Cleveland Clinic, we use Epic. ACMC is also integrated within our medical record as well, continuity. And so they can see your labs, lab data, any progress notes or a visit consultation written by a provider, your vital signs, okay, any plan of care, your imaging. Most of the time they can actually see the report of the image and they can actually view the actual image. Medications, physician orders. And the electronic health record is beginning to become more of a logic tool where they're building in checklists for safety. Okay? Patient safety is huge. Evidence-based care alerts that will actually pull components of your record together and pop up an alert saying, this patient appears to be at risk for a physiologic decline. It looks like they have a bad infection and we need to get in there right now. It can do that quicker than someone who's combing through your record. And predictive modeling is the same way. It can predict patients who may be at risk for a blood clot, or sometimes it can predict patients who are at risk for falling in the hospital. So that's kind of like step 2 of the electronic health record. We have the integration of all your information, and then what do we do with it from there to help improve your care and make it safer? So where we are headed is emerging technologies. And emerging technologies involve apps, phone apps, or computer programs to help you manage your care. Many insurance policies now require some type of participation in a chronic care management program where you're reporting back and it's really helping you become involved in your care. But what we're also doing is working on the concept of telemedicine. And so telemedicine is just the provision of care from a distance. So early telemedicine was done via phone. Telemedicine technology that we have now is done usually via two-way communication, AV communication, and some pretty sophisticated monitoring. There are some actually, before I go on to other telemedicine, they are working now for, on an application for those in the community who are at risk for falling, that it would be kept on a phone in a pocket, and the accelerometer on the cell phone would actually determine when the patient was having a fall event or having, looking like they were about to fall, and then that would alert responders to come and help that patient. So really the sky's the limit with technology. Okay? So telemedicine, again, providing care for patients at a distance. We have different telemedicine technologies that we employ within the Cleveland Clinic. One of the earliest ones that we did was give patients with heart failure a scale, and we would call them. They have scales now that are Bluetooth scales that actually upload the weight and send it right to the office. And they're tracking the weight gain, which would signify a worsening condition for heart failure, and they can make that phone call to the patient and do an early intervention to prevent that patient from coming into the hospital. Now I'll talk about my version of telemedicine. I want you to kind of come with me for a minute, and hopefully this will never happen to you, but if it does, we'll tell you what we can do. So you've been admitted to the ICU with shortness of breath. Tests have been completed, and your doctor's waiting for the results. You're tired, and you finally fall asleep. About an hour later, you start to feel a fluttering in your chest. You find the call light and ring your nurse to tell her something just doesn't feel right. Your nurse comes to your bedside, immediately performs a thorough assessment of your vital signs and heart rhythm. She knows she needs some extra support immediately, so she actually just pushes the button on the wall. And that button looks like a doorbell. Okay? When she pushes it, it lights up blue. At the same time, miles away, up to 50 miles away, sometimes even a world away, but in my case, 50 miles away or so, a team of critical care staff receive an alert that your vital signs have changed, because the electronic medical record is feeding into a complex algorithm that actually signifies a physiologic change in your status. And they open up your chart. When they open up your chart, this is what they see. So they touch here. Immediately, your medical record opens up here. Your last images open here. They see a duplicate of the monitor that's at your bedside, and they have the option of opening up a camera in your room to take a look and see how you're doing. Okay? So they've opened your chart and they take a look. It's simultaneous. It happens when your vital signs change or reflect a change in your condition, or when a nurse requests help. So an alert appears on the screen while they're looking at your chart to let them know there's a request. All they do is they hit answer. They answer the call. When they answer that call, the TV in your room turns on, and there's somebody, you see a face. You see the face of the nurse practitioner or the nurse or the critical care physician on the other side who has seen your medical record and knows there's something going on. At that point, when the TV turns on, you can see and hear each other. That nurse practitioner has a camera that is so fine, she can zoom in and she can see the size of your pupils in a dimly lit room. So she can perform a really accurate assessment. The only limitation in this system is ears. We can't put a stethoscope on the patient yet. So the nurse practitioner sees you, she manipulates that camera, she performs an assessment, she recommends immediate testing, and she places the order for that testing in the integrated medical record. That order goes to the appropriate route facility in your hospital, and those tests are performed. That nurse practitioner can watch you until you stabilize, can make a decision to transfer you to a different level of care, or can call in other specialists. So this is something that we're doing, and I just gave you the experience of patients who are in our e-hospital system. So e-hospital is ICU telemedicine. That's actually been a homegrown model developed at Cleveland Clinic. And it does just that. It pulls in all these components of the electronic medical record or electronic health record immediately. We've developed complex risk stratification systems that pull in your lab values, your vital signs. It looks at your medication record and can tell us how many medications you need to support your blood pressure. It looks at how much oxygen you're receiving. And of all the 70 patients that we monitor today, it will pull you to the top if you're the sickest patient, and we're pointed right there. So we are currently monitoring 3 facilities. We'll be up to 5 by February. And this technology does exist in other areas. Philips has its own proprietary technology called EICU. It's used, I think that the closest place it's used in Ohio is Riverside Memorial in Columbus, and they've used it for quite some time. It's a similar program where a practitioner can open up a camera and view a patient, but it doesn't pull in the data that this system for eHospital does. This is a view of the eHospital Operations Center. And so we have nurses, 2 nurses, a physician here, and this is the type of thing that they can see. And they operate in what we would call the vulnerable time from 7 p.m. to 7 a.m., where hospitals have less staffing, where it's harder to get a staff intensivist, a critical care physician, to want to be in-house during that time. Many facilities have physicians who they call at home, and they're certainly willing to take calls at home, but they can't see the patient, can't lay eyes on the patient. So this is the type of use of technology that really is the future. We're going to take this technology and possibly put it in our ambulances that transport critical patients from facility to facility. Maybe even in the helicopters and planes. We're not sure yet. We've met with NASA to help us build some of this technology, and we've done a lot of different things. So it's in its infancy for us, but the future is just wide open. One of the limitations of implementation of this technology is the infrastructure. It relies on a secure network that's reliable, that doesn't drop, where we can actually, we can maintain establishing a connection first and maintaining that connection to provide the care that we need. It's cost effective because we can deliver care to hundreds of patients with just 5 or 10 practitioners, okay? All of the information is input into the medical record, and so when the team arrives in the morning to care for that patient in the ICU, they can see everything we've done overnight. It flows into the patient's medical record, into their portal, okay? So, good. Summary. So advancements in health information have really brought the electronic health record into the 21st century. You're now at a time where you have more opportunity than ever to be informed about your health care, as well as your providers, from provider to provider, facility to facility, to have the visibility of your electronic health record. A lot of useful resources can be found on healthit.gov. There are resources for providers, there are resources for consumers. That's where I got the where we were, where we are, and where we're going. It's very, very helpful. Other helpful resources are CMS, the Centers for Medicare and Medicaid. That's the organization that sets a lot of regulations for our hospitals and what's required. They've helped determine our meaningful use requirements as well, because they pay a pretty significant amount of reimbursement to the hospitals. If you have concerns about privacy specific to electronic health records, there's a website called HIPAA.com, which will actually give you more information about your protected health information and how it's kept secure. That's the end of my presentation, and I would love to entertain some questions. Oh, sorry.
Long-range plan
For
this entire networks, plural, integration of those networks. I had some work done at university, but I see a doctor here in Nashville, and they have to fax things back and forth.
Yeah, they still do, and they still do. And if you have a CAT scan done at UH, you have to go to the department and pick up a CD, right? So there are different ideas being thrown around. There's one called, I'm not sure about UH's plan. There's one in the clinic health system called Dr. Connect. Dr. Connect is a portal that allows read-only access to all of your medical records from non-Cleveland Clinic facilities or physicians, and you give permission for that. So we'll just say this, you get all your care at the clinic, and then you decide you want to switch to UH. You have got thousands of pieces of paper records that they would have to run off for you and create for you. You give permission for them to access that. It's a faxed form. They turn it on. They use a password. It's a secure password. They can see that, and they can only see that for their patients that they have access to, so they can't see it for everybody. And there's the continuity of care. When I worked at a non-Cleveland Clinic facility for a brief amount of time, that's how we did it. We would receive patients from different facilities, and we accessed them that way. Another benefit that I forgot to mention is the record keeping. If you had a scan done 10, 15 years ago, they may no longer have a copy of the actual image for that scan. And so that may be something that has to be repeated. I recently got into a situation where I needed to call a hospital in West Virginia requesting critical records for a patient, but they were from tests done 10 years ago, and they said, I'm sorry, we just don't keep it that long. And so those were all things that needed to be repeated. So that's one of the things that's not quite developed yet, but there are ways to do it. And it's read-only. Yes?
One of the things that a lot of rural areas struggle with is the issue of broadband internet access and advanced telecommunications. I wonder if you could speak to the importance of that issue and being able to utilize the technologies you described.
Sure, absolutely. So it all relies on that. It has to be there in order for everything to work. Because it needs to be reliable, it needs to be accessible, and it's the foundation. if you have that foundation and infrastructure to support the technology can grow up from there. And so in some of our own facilities, it's required rewiring, a little bit of remodeling. It's been a challenge, but for places where it's a widespread issue, that's one of the first priorities.
Thank you.
Thank you. Any other questions or comments? Hi.
I last worked in a hospital probably close to 10 years ago at this point, and whenever we would have Joint Commission accreditation visits, they would actually want to see the paper health records, medical records to go through. Have Joint Commission standards for accreditation changed to include EHR?
Yes. And so anytime you have a surveyor come, whether it's Joint Commission or Ohio Department of Health, they sit with somebody rather than taking a paper chart into a room, which you're probably most familiar with, and they lock that room and then they look through it. They will have somebody sit with them, click through, because they're not familiar with the intimate details of every single electronic medical record. But they'll have somebody facilitate that, and they're very, very good at asking questions to find what they're looking for. And so there's no hiding any information from them because they're very astute. They know what to look for. And they seem to send surveyors who are familiar with your electronic medical record to your facility. So they're not coming in cold and having to learn what to look for.
Sorry, I have another
No,
question.
that's fine.
From an economic development standpoint, I think we've seen tremendous growth in healthcare. It's the largest employer in many communities. What's your outlook in terms of what you're seeing in terms of telemedicine and the occupational growth that is associated with that, jobs that are created?
Absolutely. So the growth associated with it is nursing. Nursing has a huge opportunity in telemedicine, as well as physicians. And it can offer a cost savings as well as job opportunity. So it's a cost savings to facilities who employ maybe an agency of house physicians overnight. We can actually, at a lower cost, offer an intensivist physician, pulmonologist or anesthesiologist or cardiologist who's familiar with that facility and familiar with that medical record or has, the access to that medical record to provide that coverage. I said the limitation of the e-hospital system right now is that it doesn't have a stethoscope associated with it. The way it's working, we actually have an outreach of e-hospital that uses a robot from a company called InTouch. And that robot actually does have a stethoscope where they bring the stethoscope, it comes in a robot, it's a face again. It's a little bit, sci-fi looking, but they can put that stethoscope on the patient's chest or abdomen, and that practitioner in the hospital operations center can hear exactly what the nurse would hear at the bedside. And so it's cost savings, it increases efficiency, but then again, opportunity for employment within this. As there's expansion, it's not that we will always run hospitals with just one physician. As we grow and grow, we'll expand to 2 physicians. We'll expand to a pulmonologist and a surgeon to meet the needs of our coverage. We've incorporated critical care nurse practitioners as well to meet the needs of the specialties. Yes?
This system seems like it would take a tremendous amount of technical support. Are you finding those people that have those technical skills, those cybersecurity skills and all of those, is that a challenge as much as finding the nurses and doctors that work with it?
So it has not been a challenge, and you're absolutely right. It does. It's huge, and it's our structure. It changes all the time, mostly because it's a homegrown product, and so we can customize it to look however we want. We are lucky to have acquired a developer who can just turn on a dime, and also upgrade security and maintain that. So we have an information technology side, and we have a clinical side. So I'm part of the clinical component and clinical development, and then that other side does the IT and programming. And we have not actually had any challenges with finding qualified people. They may not have a healthcare background, but the clinical component helps with that development. So we merge together. And so I understand a lot more of the information technology than I did 2 years ago. And they understand a lot more of the health component as well. Yes, back there.
The clinic has a tremendous amount of residents and medical students way the education system works with these students based on the fact that this is where it's headed. And our traditional education for our healthcare professionals doesn't include a lot of it.
Absolutely. So when we did a little bit of research before we started this, we actually assessed responsiveness to the application of telemedicine. And what we found was that most people hadn't heard of it. People who had graduated within the last 1 to 3 years, nurses especially, had heard of some component. Residents, not quite as much at all. And for the facilities that have residents where we're active, and actually that will be all by the end of this year, they are included in their ICU rotation. They are working with the e-hospital. And so there's no specific curriculum that I'm aware of that they've added to the residency training for working with telemedicine and telehealth. It's the standard of care in the units where we're monitoring, and there's a rotation through there. And so those residents are integrated into the standard of care. Our intensivists and nurse practitioners, mostly intensivist pulmonologists, are actually supervising the residents overnight. And so they get used to that element of telemedicine presence. But it's critical, it actually will be critical to introduce nurses, socialize nurses to the concept. The more they know about the concept, the more they're apt to use it. The more they use it, the better care they're able to provide. Even for nurses, if they're brand new grads and they have not seen a particular technology or diagnosis or procedure, they can hit that button in the room and they can talk to one of our nurses, and one of our nurses can walk them through it. Any other questions?
What can the county employers do to, get their employees to be more active and use the system? Is there you got any documentation?
That's a great question. On healthit.gov, there actually is some documentation. I think people don't use it because they think it'll take time and they're nervous about having that portal open. Like through my health insurance or through the insurers, sometimes people are forced into the technology and then they find it very useful. I don't have anything offhand, but I know that there are plenty of things about dispelling the misrumors and also recruiting people. And it's one of those things where they suggest to employers, physicians' offices, providers to continue to bring it up at every visit. Have you signed up for this? Do you wish to sign up for this? Nobody will automatically register you for a patient portal without your permission, so you have to sign a release and sign a form. And so it's bringing it to the forefront, showing benefit, and there really is benefit. It's a time saver. It probably sounds like I'm biased. I'm not paid by my chart or anything like that, but it is a time saver and it does improve efficiency. And so bringing it to the forefront, making it something that's discussed really, that people are aware of. Yes?
Could you speak to the virtual health component that Cleveland Clinic has implemented with their doc-in-the-box type of?
Yeah. So I have limited information about that application, but what they've offered now is a physician who is, it's 24/7 access to a physician ready to do some assessment, or these doc-in-the-boxes where they're using the technology for looking, listening, assessing remotely. I've never gone into one of the health pods. Has anyone gone into a health pod? Or have you seen them? They look like a photo booth, but you go in, you click some buttons. Sometimes there's a nurse or a nursing assistant who gets your visit started, and then you walk in there. And so that's one of those things that I think that will be more easily adopted by people, maybe the more techie crowd, because it's a little bit foreign. I may even be just a little bit, it'll take a little bit for me to walk into one of those pods. But it's distance health. It allows one qualified provider to do quite a bit more from a distance. And then so they also have remote consults, which are available 24/7, again, overnight with a physician. They're making a whole kind of a distance health area campus where eHospital will be located along with the physician consultation, and as well as our central monitoring unit, which monitors heart rhythms for patients at almost all the Cleveland Clinic facilities. All right, well, I promised I wouldn't go over. I'm 2 minutes over. So if you have any other questions, I'll stick around. I appreciate your time. Thank you very much for the opportunity to speak.
Thank you. I found that really fascinating, really a great presentation, a lot to think about. Thank you all for being here this morning. We're really lucky with the weather. I can't believe it's December and we don't have any snow out there. We're taking January off, so we will see you in February. I hope everyone has happy holidays. Thank you.